Hi, everyone. My name is E. David Crawford, and I'm editor-in-chief of Grand Rounds in Urology. Last month, I was at the Western section of the AUA meeting, and I heard a number of brilliant presentations, but several were from a resident at Mayo Clinic in Scottsdale, Dr. Logan Briggs. And it focused on challenges that we all face, and that's sort of high-risk people in surgery and rehabilitation and recuperation. Logan had 4 presentations on various urologic surgeries of bladder, kidney, prostate, testis, and sort of some implementation and ideas how to deal with that. We all see patients who are not the ideal surgical candidates because they're overweight, they don't exercise, and matter of fact, we have an obesity problem in the U.S., as we all know, and we also have a lack of what is felt to be the amount of exercise we should do every day. Only about 35% of people do that. Logan tackled that, and he's going to share that with us right now. Logan sent me his CV last night, and I was very impressed, and I sent it to a couple of my friends. Scott Sellinger came back and said this to me: very impressive. I'm worn out just reading all his accomplishments, and a marathon runner too. Logan, you really have accomplished a lot, and I'm glad that you're here with us, Grand Rounds in Urology, to share some of these findings.
Thank you for having me today, Dr. Crawford, and thank you for those kind words. It's really an honor to be here and to talk about a topic I get so excited about. I wanted to first give a shout out to my main mentors, Dr. Sarah Sudka at University of Washington, Sarah Park at Mayo Clinic, Arizona, and Kwok Trin at Brigham and Women's. But this project has been a multi-year and multi-institutional collaboration, so I'm very happy to be sharing some of our findings today with the Grand Rounds in Urology community. As we all know, urologic cancers are some of the most prevalent, and they come with significant morbidity. And they've been the target of many rehabilitative efforts to date, and no holistic summary exists. So our goal was to summarize the efficacy of all interventions performed to date, and then use that to guide further efforts as we move forward. So to do this, we performed a scoping review, which is methodologically similar to a systematic review, just the search question is much broader. And we included randomized controlled trials alone, where urologic cancer patients or their caregivers were enrolled in any type of pre or rehabilitative program that measured any type of clinically relevant outcome. Our systematic search yielded 372 RCTs for prostate cancer, 24 for bladder, 20 for kidney, and 14 for testicular cancer. And I'll just go through kind of the main overarching findings as quick as I can for each cancer type. But this is for prostate cancer, and this is an alluvial diagram, which summarizes all 372 RCTs for prostate cancer, showing the type of intervention on the left, so exercise in red, psychologic support in orange, etc., and our outcome categories on the right, with colored bars being significant findings, gray bars being insignificant, and the width of the bar being proportional to the number of studies. So just looking at this, you can kind of get an idea of what types of interventions have been done for men with prostate cancer and the types of outcomes they've measured and how effective they've been. Just as a quick example, so you can kind of get how this alluvial diagram works, this is a study that found that postoperative pelvic floor muscle training with additional physiotherapist follow-up significantly improved continence rates compared to without additional physiotherapist follow-up. But overall, for prostate cancer, we found promising interventions included web-based or automated patient counseling and education, exercise, pelvic floor muscle training, biofeedback, electrostimulation, electroacupuncture, physical therapy, and postoperative penile therapy, psychologic support like cognitive behavioral therapy, and mindfulness training. So there are a lot of studies here. For bladder cancer, we found 24 randomized controlled trials. And again, just as a quick example, this study found that preoperative immunonutrition significantly improved infectious complications after radical cystectomy. Overall, looking at all the studies, what stands out are interventions having involved exercise, and especially when combined with psychologic support, such as stress management training, cognitive training, smoking and alcohol cessation counseling. and then other interventions like immunonutrition, stoma education, and penile rehabilitation. For kidney cancer, we found 20 RCTs, and this is a smaller alluvial diagram because there were no physical therapy or pharmacologic interventions. But again, just as one example, this study looked at 182 patients after radical nephrectomy for RCC and randomized them to a 12-month intensive patient care program, including personalized physical training recommendations, counseling, emotional support, and patient education, all that versus usual care. And they found that this multimodal program improved anxiety and depression significantly. But overall, for all the kidney cancer RCTs, we found benefit in nutrition interventions, including preoperative carbohydrate drinks, which are talked a lot about, homeopathic aids for those on systemic therapy, communication aids, exercise, again, interestingly, especially when combined with psychological support or psychological support alone, including stress self-management training, expressive writing, mindfulness training, behavioral counseling, and cognitive behavioral therapy. For testicular cancer, there were 14 RCTs, and I'll just say that the data in this space are extremely limited. Many of these trials included a very small number of testicular cancer patients, and the trials overall included mostly other types of cancer patients. But as one example, this was a really cool study that found 12 weeks of high-intensity interval training for testicular cancer survivors significantly improves fatigue, depression, anxiety, stress, self-esteem, sleep quality, health-related quality of life, and then a bunch of cardiovascular disease risk factors that I won't go into. But overall, we found promise for high-intensity interval training for testicular cancer survivors, as well as psychological support like expressive writing and self-directed stress management. So that was a lot. But the 30,000-foot view of all of this is that there are a plethora of interventions out there that we as clinicians or urologists may try to implement. And most, or 71% of those, have demonstrated statistical significance. And I think the key in this is really to identify those that are clinically significant, and even better yet, those that are most cost-effective and implementable. So to this end, we as urologists should remember to utilize our colleagues and ancillary support staff to try to implement some of these interventions for our patients. Aside from implementing the most promising interventions, further work needs to examine cost effectiveness. Less than 2% of studies actually looked at that at all. And the impact of programs on caregivers, keeping in mind how integral they are for example, caring for our frail bladder cancer patients, or the impact that prostate cancer treatment has on sexual health, which impacts both partners in a relationship. And then finally, differential efficacy by race and ethnicity. Less than 1% of studies looked at that, but all four studies, and that was 4 studies total, and they all showed that their intervention was variably efficacious depending on race. So, there's a lot we can do, and this is going to be one of the foci of my careers going forward is how to effectively deliver this support to our patients and deliver a cost-effective, personalized, targeted, multimodal pre and rehabilitation program. But thank you again for having me today, and it's been an honor to be here.
Logan, thank you very much. This was going to be very impactful for our audience of Grand Rounds in Urology. A question, as you well know, and you're working with us on this, we're very focused on androgen deprivation therapy and side effects, particularly cardiovascular. We have to do something about this. This is a major issue, and there's a lot of stuff coming out right now. If you had to tell our audience in about 1 minute what you think ought to happen, please do.
Yeah, great question. Fortunately, this study topic, pre-rehabilitation, rehabilitation, focuses on exercise, diet, nutrition, psychological support. These are all extremely relevant things for our patients on androgen deprivation therapy. Among the 372 RCTs for men on prostate cancer, a good number of them were revolved around men with ADT. And I think the main things that we need to look out for with ADT are, like you mentioned, cardiovascular risk factors, but also bone health and mental health with fatigue and sexual health kind of being effective pretty significantly by ADT. And there's a lot we can do from that standpoint. So I think that what we need to do as urologists is come up with, a lot of people have already done a lot of great work, including, you, Dr. Crawford, on this, is identify these risk factors for cardiovascular disease, osteoporosis, and mental health, and then, risk stratify patients. And if they have these risk factors, then do X, Y, and Z, whether that includes cardiovascular monitoring, treatment. There's a lot we can do for osteoporosis treatment with different medications. I think for cardiovascular disease, diet and exercise are huge, and we can do a lot on that front. So I think there's a lot of work we can do going forward, and I look forward to contributing to all that great work.
Thanks for that, Logan, and we'll be in touch in the future for more grand rounds and urology presentations.